All right, so we are recording the lecture today. So a couple things to keep in mind. You do have a quiz that should be open and available today. Please check and make sure that it is. Okay, it is. All right. Because of the problems we had with last week's quiz, I'm just going to delete it out and take it away. There were some rhythms you hadn't covered. There were others, people that didn't get to it, and because it didn't open up until Thursday, then we some folks just didn't do it at all. So that's my fault. I'll take the hit on that. So as far as this week, understand that this week's quiz is a rather lengthy one. It's only rhythm strips. Okay, it's only rhythm strips. But, again, keep in mind, you can take the quiz as many times as you want until you get the score that you want. But don't wait until Sunday to start it because it's going to take you a while to get through that. We'll talk more about what your assignment is for next week, which is spring break. Hopefully everybody's going to do something for themselves. And we'll talk more about that Wednesday. I also have the quizzes from your last class. Scores were really, really good. I had at least one, maybe two people in here that, when you go in and you identify things like atrial flutter and you tell me what the ratio is, or if you identify a sinus rhythm with a PAC, if you tell me, it's a second and the seventh one there, I give you a 50% bonus. So I think at least two people actually scored 105 on the quiz. So I was just really, really pleased with the overall score. And I've been really pleased with the overall ability of this particular class in general. So I will give those back to you at the end of class because I didn't want to go that because someone's signature was unreadable anyway. So I didn't call any names, Catherine. So anyway, let's get started. So we're going to continue on and work on AV blocks. Okay? And in this one, what we're going to do is we're going to move now from secondary type 1 block, which is kind of Travis, we're going to look, we're going to watch, but we're not going to really get too concerned. Now we're going to move into secondary type 2 block, which makes us go, there's something going on with our patient, okay? Now, let me get my remote to working here. So, it is also called a Mobitz 2, okay? Secondary type 1, you can call a Mobitz 1. Secondary type 2, you can call a Mobitz 2 as you want. Basically, what happens in this is that you have a fixed PR interval, and every second, third, fourth, fifth, whatever QRS is dropped. So remember, under a normal conduction system, the impulse starts up in the atria, usually at the SA node, comes down to the AV node, gets held up there for a fraction of a second again, so that the atria and the ventricles can contract in an offset manner, and then it gets sent on down through the ventricles. In second degree type 2, what happens is now that impulse comes down, gets held up, and then it gets sent on. Impulse comes down, gets held up, gets sent on. Impulse comes down, gets held up, and never gets sent on to the ventricles, okay? In a second degree type 2 block, you can characterize this as a 1 or 2-to-1, 3-to-1, 4-to-1 block. Basically, what that means is that you have 2-to-1 would be 2 conducted P waves with a QRS to 1 non-conducted P wave. Now, it's important for you to understand when I say a non-conducted P wave, that does not mean that there is not a P wave that is generated, because there is. So the P waves go in there, and basically what happens is it gets held up the AV node, and there's no QRS. So just for fun, It's hard to tell, but now keep in mind this pattern right here, if we went on out over here, or if we were looking at it earlier on this side, this pattern is going to repeat. This is one of the reasons why when we started with this class, I said that when a pattern is irregular, the next question we wanted to find out, does that pattern repeat itself? Okay. And in doing this, basically what we're looking at here is what's called a high degree block that we should be concerned about. Now, if you were to characterize this as a ratio, what would you call it? 2 to 1, 3 to 1, 4 to 1, 5 to 1, what? Who said 3 to 1? I heard somebody.
I said 2 to 1.
Okay, so why are you saying 2 to 1, Catherine?
There's 2 P waves and then there's the P wave with the QR.
Okay. Travis, did you say 3 to 1?
I said 3 to 1 and then 2 to 1.
Okay. Now, okay, so in essence, what we're only able to look at, let me grab my little highlighter here and do some.
There's 3 to 1 and then 2 to 1.
So when we're looking at the ratio, this is what we would be looking at. What we're looking at here is the 2 to 1, 3 to 1, 4 to 1, with the first number would be the number of complete complexes that we have, P wave QRS, to how many dropped QRSs that we have with a P wave only. So in this situation, what we would be looking at here, and I'm telling you this because I want everybody to understand it, because I like giving you all extra bonus points when you know the material. We have 1, 2, 3, and then we have 1 P wave and a dropped QRS. So that would be a 3 to 1 conduction ratio. How many complete complexes do we have? 3. To how many non-conducted P waves we have? 1. Go here and then back here.
What about the ones that come before it?
So now, again, this is really important. This is a good question. This is what I was saying, is that if we want to conclusively know what this is over a longer period of time, we would have to know what came before it and what comes after it. So that would be one of those situations of where we'd either print off a longer strip or we would look at it on the screen of the monitor to see exactly what is happening. Does that help? So you can't really utilize this in here because it's incomplete data. You can't really utilize this in here because it's incomplete data. The only thing that we know for sure in this 6-second strip is that this is a 3 to 1 conduction ratio. Now it can vary, okay? It can vary, especially if this were like a 12-second or an 18-second strip. Okay? Sydney. Okay. So again, when you're looking at this, you can only go off of the information that is there in front of you for that whole complete area there, all right? Now, if it varies, let's say that you're looking at this is 3 to 1. Let's say over here you have 2 to 1, which would mean what?
2 complete complexes to 1.
Okay. Then we would call that a variable ratio. There's no set ratio to it. Okay. So you can either have like a 2 to 1 ratio, 3 to 1 ratio, or a variable ratio. And I'm okay with you putting variable ratio as long as it really is variable. Now, it's going to be difficult for you to tell from just a 6-second strip as to whether it varies or not. But as we get deeper into this, I will begin giving you strips that are 12 and 18 seconds long. And you will be able to tell the difference, okay? Now, here's the thing. Second-degree block is usually coming about as a result of necrosis. Necrosis means what, ladies and gentlemen? Say it loud. My ears are really plugged up with allergies. dead tissue, necrotic, dead tissue, necrosis. And it's usually dead tissue within the septum, and in particularly where at in the septum. It's in the name. Where? The AV node. Okay. So we've got dead tissue within the AV node. All right. Now let's think for just a minute. What can cause this dead tissue? What is the most common cause of dead tissue in the heart? Heart attack. Yeah. So we got a blockage in an artery and the blood can't get through. And so blood can't get through, oxygen can't get through. So the tissue that is distal meaning beyond that blockage, begins to die off. Okay? And that it becomes necrotic tissue. Here's the thing to remember. Okay, you'll hear me say this multiple times between now and the end of the semester. And then those of you that are coming into the sequence, you're going to get sick. Oh my goodness, Dr. Young's at it again. Necrotic tissue does not contract. Necrotic tissue does not conduct electricity. So in a heart that has a large amount of dead tissue or infarcted tissue, infarction and necrosis means the same thing, several things happen. As far as the pumping action is going to be diminished, which means what for our cardiac output? It's going to be diminished as well. Yeah, you're exactly right. So it's going to be diminished. The other thing that happens here is, remember I said that it does not conduct electricity. So one of two things happens. One is either it comes down, this is its normal pathway. If there's dead tissue, it does this and takes a bypass and goes around. Or in this situation here with high degree AV block, it comes down and it never gets through. Did you have a question?
Well, it was just more of a simple question. So pretty much the only way for us to identify the second degree of block type 2 is on a longer strip.
You can identify with a 6-second strip because here's the things that you're looking at, okay? Within your blocks, most of the time, the aberration or the abnormality is going to be in your PR interval, okay? So when we look at this particular rhythm right here, okay, same thing that we've been looking at, we can see that PR interval. Now remember, you're still going to take and use the 5-step process. What's your rate? So what would be your rate in this rhythm? 50, okay? So we already know that it's what? It's a bradycardia. Even though we don't call it a bradycardia, it's a bradycardia. It's not unusual for your high-degree blocks to be slow. Keep that in mind. Your rhythm is what? Regular or irregular? It's irregular. Is there a pattern? Well, we can't really identify whether there's a pattern or not, but we can tell that there's some irregularity. We look at our P waves. Are there P waves? Yeah, there's P waves. They go right along in through there. Do the P waves look similar? Say again? Yeah, they do. Which tells us what? Coming from the same impulse. Coming from the same impulse site. Now we look at our PR interval. Ladies and gentlemen, this is going to be critical to get really good at blocks. What do you see about your PR interval? Say it again. True, there are some missing PR intervals because if you don't have a QRS, you don't have a PR interval. But of the PR intervals that are there, they're all the same, okay? What else do you notice as far as their width? They're normal. Now, understand this. In second degree type 2, You can have normal PR intervals or you can have long PR intervals. Here is the key for second degree type 2. The PR intervals are all the same. They don't change. Remember with second degree type 1, what did you see with the PR intervals? Yeah. So we started out with a PR interval, then it got longer, it got longer, it got longer, and then we had a P wave, no QRS. With second degree type 2, start out with a PR interval. Your next PR interval going to be the same width. If there's a next PR interval, it's going to be the same width. And then we have a P wave, no QRS, no PR interval. Okay, and so that's going to be the key that we're looking at here as far as identifying this. The other thing, yes, Matt.
So for second degree, or the
Now, which second degree, which one? Because remember, you got type 2.
So will the length or the interval from P wave to P wave always be the same? It looks like it's all the same.
It depends. And you will find I say that a lot about medicine because, again, your patients haven't read the textbook. Most of the time, your P to P intervals will be the same. Now, I will give you a preview of a coming attraction here that we'll talk about in just a minute. When we get to third degree heart block, measuring your P to P interval is going to be critical, okay? Measuring your R to R interval is going to be critical. Just hold on to that for right now, and we'll come to that in a second. But most of the time in secondary type 2, your P to P interval, the distance between them is going to be the same. Good question. Good question. So, your QRS is going to be narrow. Why will your QRS be narrow? This goes all the way back to like the second week of class. Why is your QRS narrow within normal width? Yeah, there's nothing wrong with the ventricles. The ventricles are working just fine. The problem is where? At the AV node. At the AV node. All right, so that's critical to remember. Here's our 5-step. We just did that, okay? Your atrial rate is normally going to be up between 60 to 100. Why? Because the atria paces at 60 to 100. Because of the dropped QRS complexes, your ventricular rate will almost always, not always, but almost always be a bradycardia. Okay? Be a bradycardia. Your rhythm can be regular or irregular. Can't really tell. We know with this one it's irregular, but we can't really tell if there's a pattern until we look at some additional complexes going beyond it. All right. P waves all look normal and they all look similar. Why? It's because it's coming from the same pacing point within the atria. Okay. Your PR interval, this stays the same. Now understand again, this little statement right down in here. Your PR intervals may be greater than 0.2 seconds. This may lead you to look at that and say, oh, well, that's a sinus arrhythmia with a first degree block. No, it's not. No, it's not. Okay. It is going to be a second degree type 2. Again, because you have that dropped QRS after a P wave that doesn't conduct all the way through. Again, now it says in here that your QRS is often greater than 0.12 seconds. It can be. It can be. But usually it's going to be 0.12 seconds or less. All right. So let me ask you a question. What's the big issue with a secondary type 2 block as far as your patient goes? Why did I tell you when you see a patient with a secondary type 2, you need to sit up on your seat and you need to focus in on your patient.
Could lead to like AFib.
Not AFib, even worse than AFib. Look at that rhythm and tell me why that rhythm could cause problems for your patient.
Because there's no electrical conductivity for the ventricles.
And then there's no what else?
Blood flow.
Yes. Everything falls back on blood flow. Remember, what's this guy's heart rate? How many people do you know that have even a resting heart rate of 50 and are healthy? That's because you are in excellent shape. You probably run and work out, right? People such as yourself, people that are in really good physical shape, can indeed have a heart rate of 50. But I can guarantee you, Travis, your EKG doesn't look anything like this because your heart is healthy, all right? Folks that are in the military, law enforcement people that are very, very healthy, and they exercise a lot and they run a lot. Elite athletes, especially elite athletes that take part in long distance type of events, marathon runners, triathletes, their resting heart rate can often be in the 50s, okay? It is possible to have a resting heart rate and not be an athlete and be in the 50s as well. I don't have my watch on. My heart rate will drop down into the 50s every now and then, but that's because I'm on a beta blocker, all right? But my heart rate doesn't look like this. This tells us we've got a conduction abnormality that is leading to just what Matt said a while ago, decreased cardiac output because it's too slow. It's too slow. It is not good for our patient. Now, your patient may be able to compensate with other parts of the body taking over and keeping a good blood pressure for perfusion to the brain, the heart, and the kidneys. But he or she may not as well. But again, when you see this particular patient, you got to focus in on them and watch them, because what we don't want them to do is to move from a second degree type 2 into a third degree block. Now you're going to get busy because there are some things that you're going to have to do for this patient. Okay? Any questions on this? Now, the next slide talks about the treatment. Basically, remember, we treat our patient, we look at our patient, we see how they're doing, we look at their vital signs, and if they are symptomatic, meaning chest pain, pale, they're diaphoretic, sweaty, altered mental status, then we treat them. But if they're stable and they're doing okay, we watch them, we observe them. But we want to watch this patient really, really closely, because if the heart rate slows down, we've got two routes to do. Number one, and you won't get you won't have any questions about this on your quiz this particular week, because I just want you to identify it. We can give them a drug called atropine, or we give them little intermittent pulses of electricity that artificially pace their heart and speed the heart rate up. We'll talk more about that treatment towards the end of the semester. Speaking of which, your next exam, and we'll try to get your study guide, which will be really simple because it's basically just going to be EKGs, ready for you by Wednesday, will not be the week after spring break, but it will be the following week. So 2 weeks after spring break, on Wednesday, we'll have your second exam. 90% of that exam is only going to be EKG rhythm strips that we cover prior to the exam. All right, so just kind of keep that in mind. Stay tuned for more information. All right, so as we look at this one, take a look at this. First of all, understand right there is our hash mark, and right there is a hash mark. Okay. So somebody tell me, what is the rate on this patient? 40. Okay. Even for really elite athletes, unless they are like Olympic athletes, a resting heart rate of 40, no bueno. Okay. Not good. Not good. Rhythm. Okay. Hold on now. Because remember, this is going to be a second degree type 2 block. Remember a while ago, the one we saw earlier, that one right there, it was irregular. Okay. We're going to have a secondary heart block here that is actually going to be regular. I'm going to ask you why in just a minute. Do you see P waves?
Yes.
Do they look normal? Do they look similar? Okay. Does every QRS have a P wave? Does everybody see that? Okay. Let me make sure. QRS, P wave. QRS, P wave. QRS, P, QRS, P, QRS, P. Does every P wave have a QRS? No, we got several, okay? P wave, nothing. P wave, nothing. P, nothing, okay? When you see that, ladies and gentlemen, that is a hallmark sign that you got a heart block of some flavor. Now, what we got to do is we got to dig deeper down in there to figure out which one of the 4 heart blocks it is that we have. What do you notice about the PR interval? Normal and what? Normal and constant. Does everybody see where, let me enlarge it for you just a bit. Can you see there that you have a normal width PR interval and it is almost identical for those 3 complexes? Anybody not see that? Okay, good. What do you notice about the QRS? It is also normal, which tells us even though that impulse is getting blocked at the AV node, the ones that are getting through are following the normal conduction pathway. Okay? So this is a second degree type 2 block. Why is it regular? Whereas that one was irregular. Say it again. I'm sorry.
There's a pattern.
What about the pattern? So the pattern is regular. I'll agree with you on there. But what makes the pattern regular? The R to R intervals are the same. Tell me, what do you mean? What do you mean by ratio?
It's 1-to-1.
This you would identify as a 1-to-1 block. Okay, that means you've got one complete QRS and P wave, one P wave that gets blocked. Does everybody see that? Please don't be bashful. If you don't see that, okay, good, thank you.
Well, I see it, but in the book, I'm looking at the same strip, and it says that this is a 2-to-1 with an AV.
Okay, this is one of those situations where the book and I are going to respectfully disagree. And so I will tell you, in this situation, it's not my ego or anything, but this is the nice thing about cardiology is that you can have differing opinions on what you're seeing, but because this is an initial information course, I want you to, on this one thing, I want you to do it my way, okay? So we would call this a 1-to-1 block, okay? One complete set of complexes, one blocked P wave. It doesn't get through. Thank you for bringing that up. Anybody else? Any questions about this particular rhythm that makes it a second degree type 2? Everybody see why a second degree type 2 can be a problem for your patient? Which is, what's the problem? Lack of blood flow due to what? Muscles?
Ventricles. Ventricles.
The ventricles not doing what?
Contracting.
Contracting. So the heart rate is too slow. The heart rate is too slow. Let's look at another one. Rate. Rhythm.
Regular.
P waves. Do you see them?
Yes.
Do they look normal?
Yes.
Do the P waves all look similar?
Yes.
What do you notice about the PR interval?
Regular.
So the best wording here to use rather than regular is normal or abnormal and constant. That basically means that the PR interval does not change. So we would see in here, as I'm looking at this, this looks like a normal PR interval that doesn't change, so it would be constant, okay? Does every P wave, or let me back up, does every QRS have a P wave? Okay, does every P wave have a QRS? No, it doesn't, okay? And so what do you notice about the QRS?
It's normal.
Okay, good. So again, how would you identify this ratio? So you have 3 complete QRS complexes and P waves to 1 P wave, or is it the other way around? So basically what we've got here is we've got a 1 to 1, 2, a 1 to 2 ratio. You've got 1 complete set of complexes to 2 blocked P waves. Everybody see that? Okay. Because the last place I want you to struggle with this is on Wednesday when you have your next quiz, and it'll only be AV blocks for Wednesday. That's all it's going to be.
So
Yes.
Just to confirm, when you want the ratio, you want the number of QRSs to P waves, not the number of P waves to QRSs. So
Correct.
this wouldn't be a 2-to-1 because there's 2 P's and 1 QRS.
No, you've got one complete set to 2 blocked P waves, and we see that it repeats itself going over here and here. So you are correct.
I was just confirming because one of your slides earlier said the opposite.
This comes from the textbook. So I built my slides from within the textbook. And so when you see something, a discrepancy like that, do exactly what you're doing right now. Question it. Just to make sure. Yes.
So we know that we can have electrical activity without actual physical activity. Can you see any of these rhythms without the heart actually doing anything?
So what you're asking is it possible for this QRS to just simply be electrical activity and no mechanical activity?
Yeah.
I got to tell you, nobody's ever asked me that question before. The answer is yeah, it's possible, but it's not likely. That's a really good question. It's possible, but it's not likely. So again, one of the things, and the question that you raised is going to be critically important because when we talk about ventricular arrhythmias, we're going to talk about an arrhythmia called pulseless electrical activity, which is basically you see electricity on your screen. Could be this right here, or it could be the prettiest normal sinus rhythm you've ever seen in your entire life. And when you go to check a pulse, primarily you want to check a carotid or a femoral pulse, there's no pulse, and your patient is in cardiac arrest. So in that situation, most definitely you would see that. Most of the time, these are going to be conducted, but again, anything is possible. So let me ask you a question, follow-up question to yours. If this did not result in a pulse, how would you know that? And what what would you experience while you're palpating the pulse? You wouldn't feel anything. So basically what we would have here is, let's say this one did not, this one was just electrical, not mechanical. We get a pulse here, we get a pulse here. You see this on the monitor, but you don't feel a pulse. Then it picks back up over here with this one being a pulse. So yeah, it is possible. Not likely though. Good. Anybody else? All right. This one is really similar to what we had a minute ago when we were working on the very first one. Any questions on a second degree type 2 block? Let's go to the granddaddy of them all. Third degree AV block. Also known as complete heart block. Here's the thing that is happening within the heart. The impulse starts in the atria. It gets generated in. It gets to the AV node and it gets blocked. It does not go through. Another one is generated. It gets down to the AV node. It gets blocked. It does not go through. When the heart senses that the impulse is not working, what does the heart do? This comes back to those words that we talked about as far as conductivity, excitability, automaticity. Which one of those words kicks in? Where does it happen? And automaticity is what? So where is it firing then? What part of the heart? I'll give you a hint. Look at the width of your QRS. Ventricles. Ventricles. Remember, if you get an impulse that takes an opposite direction going through the ventricles, or if you get an impulse that is generated from the ventricles, the QRS is going to be wider than 0.12 seconds. Okay. Here's what's happening. Okay. Let me come back over here to this first slide. The impulse fires here at the SA node or somewhere up here in the SA node. It's like we literally, from an electrical perspective, have two hearts now. We have the atria that's doing its thing. We have the ventricle that's doing its thing. But unlike all of us in here right now, where they're communicating with each other, there's no communication that's going on between the atria and the ventricles. The atria will fire. And because the impulse is coming from the atria, your atrial rate will normally be what? 60 to 100, okay? It gets down to the AV node, it gets blocked off. It gets down to the AV node, it gets blocked off. It gets down to the AV node, it gets blocked off. And the ventricles are down here waiting. They're looking at their watch and they're thinking, dude, what's going on? The atria apparently has taken off for the day. We're going to have to do something or this guy's going to fall over dead because there's no blood that's being ejected out of the left ventricle. Yes, I make body organs into humans. So what they do is the ventricles will now begin to fire. Okay? What's the inherent pacing rate of the ventricles? That's why when you're looking at complete heart block, you'll have a faster atrial rate than you will a ventricular rate. Here's the other thing, ladies and gentlemen, that you've got to look at to identify third degree heart block. Your PR interval is all over the place. There's no rhyme or reason. Remember with secondary type 1, what happens to the PR interval? Yeah, longer drop. Secondary type 2, what happens to your PR interval? Constant drop. With third degree heart block, it's kind of like the accordion. You're looking at your P waves and they're all over the place. Sometimes you will actually have two P waves to a QRS and then follow it up, and the next thing you'll have one P wave to a QRS. We'll show you this in the 5-step process here in just a minute. Why? Because remember, the atria are firing, but they're not talking to the ventricles. The impulse from the atria gets the AV node and gets blocked off. Because of automaticity, the ability of any cell in the heart to generate its own impulse, and the impulse being in the ventricles, now the ventricles begin to pace, and they'll pace at 20 to 40 beats a minute. That's why when you count your P waves, the normal number of P waves there will be somewhere normally between 60 and 100. The amount of QRS complexes will be two things. Number one, they'll be wide. And number two, they'll normally be between 20 and 40. Okay? Now, here's the problem with third-degree heart block. This is also known as complete heart block. Okay? The patient has lots of really bad damage done to his heart. There is severe damage done to the heart. The other thing that we're looking at in here is even though the ventricles are depolarizing and they're contracting, they're not as efficient as if the normal process takes place. So that also, normally a slower rate, also coming into play here. Incomplete emptying of the left ventricle means our cardiac output is going to be reduced. Yes?
Are you confused as to where the actual beginning of the QRS is? Is it
Yeah.
here after the P wave or is it down the bottom?
So on this one, let's look at this one right here. So your QRS actually begins here. Why? Because your QRS, this is your first positive or negative movement away from baseline. Okay? Where's it end? Yeah, that's exactly where it ends. Now, when you're looking, you're counting from this box all the way over, and it's close enough that you can count it on that other dark line. What is the width of your QRS? Yeah, which would be how many seconds? 0.2 or 200 milliseconds. That's way too long for a ventricle. Way too long. Yes.
So whenever it fires on the ventricle, will it remain in a constant in that like same space, or will it kind of be like from the essay? Kind of, well, I don't know how to explain. Like you know how it would fire from a different spot, and that in between the essay and the in this case, would it be different in the ventricles too, like where it would fire from different spots, or would it remain constant?
No. How do we know this? No. Good question. This is another key thing that we would see here. Your QRS complexes would all look similar, and your R to R interval would be within 1 to 2 boxes the same. So if we measure our R to R interval here, okay, and we would go from the point, okay, so we'd measure from here to here, and from here to here, and here to here. That R to R interval is basically going to be the same, okay. When we look at our P waves, okay, now if we were to measure our P waves, this one is not a good one to start with, but it's okay. We'll make it work. If we measure our P waves from here to here, somebody get out their laser pointer and show me where the P wave is in after this P wave. You're close. Nope, too far.
In the QRS?
It's right, yeah. So it will be right here. That's your P wave. How do I know? Compare this FLB, funny looking beat, to this one right here. This one has kind of a plateau and then it goes up. This one has got bunny ears. So this is going to be your P wave. How do we confirm it? Well, if we measure the P to P over here, it's pretty much going to be the P to P to coming back over here. So here's the thing to remember with a third degree block, okay? QRS is going to be slower than your atrial rate. All right? So you're going to have more P waves than you would have QRS complexes. Don't be surprised if your P wave is buried somewhere within either the QRS or the T wave afterwards. When you measure your R to R intervals, they're all the same for the very reason the question that you asked, and it was perfect timing on it, is that it's coming from the same impulse. How do we know? R to R is the same, and every one of these QRS complexes looks similar. The very next thing we do, ladies and gentlemen, we go back and we want to measure our P to P interval, all right? We would find out that the P to P interval is going to be the same. That's going to be your P wave right there, by the way. And over here, and over here. That P to P interval is going to be the same, okay? But I want to point something out to you. What did I tell you about the PR interval? Look at this PR interval. What do you notice about it? What do you notice about that PR interval?
Way longer.
Way longer. What about that PR interval?
Longer than normal.
Longer than normal, okay? And then we look at this PR interval over here, and if we were to look at this PR interval over here, if there is indeed a QRS after that, it would be different. So the PR interval is literally all over the place. Yes, sir.
So these little peaks here, those are P waves and P waves.
So coming off right there, that's your T wave. Okay, this is a P wave right here. Here is a P wave. Here is an embedded P wave, T wave together. Why? Because it looks a little bit wider and you've got that little notch in there as well that comes into play. And how can we verify that is if we measure it over to here, it should be within the same range. But again, the big thing to look at here is that you will have more P waves than you will have QRS complexes. Anybody else with a question on that?
One more thing.
Yeah.
Will these always be inverted?
Nope. They can be upright. It all depends upon which view of the heart that you're looking at. What I can tell you is, again, they will almost always be wide. Greater than 0.2 seconds, or greater than 0.12 seconds, or 120 milliseconds. Here's another one. What's your rate?
50.
Rhythm.
Regular.
What's regular?
QRS, correct.
Okay, so your QRSs are regular. Now, see, this is why the 5-step process is so very important, okay? When you look at this and you're thinking, we got a rate of 50, okay, it's a bradycardia. It's a regular rhythm going through the little hard drive in our brain, thinking, okay, which ones are regular? Oh, well, it could be sinus bradycardia. Maybe, I don't know. But that's why we got to go through and we got to identify all the other steps, okay? Do you see P waves? Does every Q? Oh, I mean, I'm sorry. Are the P waves? Do they look normal? By normal, anything that's upright, we would consider it normal because we'll talk about some that are inverted here in just a minute that would be abnormal. Okay, so these are pretty normal. Do they look similar to each other? Yeah, they do. Now, think about this closely. Does every QRS have a P wave?
Yes.
Mm-hmm. So we can see QRS, P, QRS, P, and so on and so forth. Does every P wave have a QRS? Somebody show me where there is a P wave up there that does not have a QRS. Oh man, you guys are so good. Say it again. Oh yeah, that one. You could probably have a laser show with that one. That's awesome. So we've got more P waves than we've got QRSs. Okay. What do you notice, ladies and gentlemen, about the PR interval? Is there a pattern to it? No. There's no PR interval longer, longer, longer drop. Or there's no PR interval that's constant, constant, constant drop. Okay? It's all over the place. Think like an accordion. It's in and out, in and out. The last part, what do you notice about the QRS? Than, which is 0.12 seconds. Okay? It is wider than 0.12 seconds. And as such, that tells us that impulse is coming from within the ventricles. Do the QRSs look the same? If you measured your RR interval, do you think they would be pretty close to the same distance?
Yes.
If you measured your P to P intervals, does it look like that they would be pretty much the same distance? So this has to be complete heart block. You just went through and did that. Okay? Go ahead.
So these, the first two, right? These two, and then you compare it to the next one. Or you count this as a P wave right here?
Yep.
All right, check it.
Yep. So as you're looking at it here, okay, let me do the laser pointer. There's our P wave. Here's our next P wave. Here's our next P wave. You measure over in here, and there, P wave is going to be embedded somewhere in there. I cannot tell you for sure if that first notch is the P wave or the second notch is the P wave, but it's one of them. Again, because it's embedded within the T wave. But as we go on out across through here, then our P to P intervals are all going to be pretty much the same. Here's the other thing to look at. What does it mean if we're measuring our P to P interval and when we're measuring it falls right in the middle of a QRS? Does that mean that we don't have a P wave? What does it mean? Hidden where? So it's hidden within the QRS. And if you want to get really, really detailed about it, if you were to come and you would measure out the QRS that you feel like that the P wave is in, you would find it is almost always just a little bit, maybe one box wider than the previous ones. Okay? Now, the big clinical significance that we see here for third degree block is that your patient is not going to have good cardiac output. These patients are in really serious danger of going into cardiac arrest. They will basically just kind of slow down until they just depart this world. Okay? There's just simply the heart rate will slow down, and then eventually stop. Yes.
So the ventricles are depolarizing at a different rate, which is why these intervals look different.
Yeah. Remember, the atria is polarizing at its inherent rate, which is 60 to 100. But that impulse is not getting down to the ventricles. Therefore, the ventricles decide they got to pick up, they got to do something. And now they're depolarizing at their inherent rate, which is 20 to 40. Now, understand that sometimes we can have a little bit faster or a little bit slower on those on the ventricular part.
Both sites are depolarizing, but they're doing it at different rates.
Correct. They're doing it at different rates because there's no communication going on. Bad things always happen when there's no communication. This is one of the things I like about y'all, is at least I get the impression you're not afraid to, like with the exam or the quiz that we just did. You said, "Hey, Dr. Young, there's rhythm strips on there that we didn't cover. You know, what can we do about that?" And my answer is, well, I won't count them against you. Some of y'all didn't take the quiz because it wasn't open until late Thursday. Okay, you let me know that. And that's the way a class is supposed to operate. If you were afraid to communicate with me, and if I tried to do a better job, but if I didn't do an adequate job of communicating with you, your learning would not take place. Same thing with the heart. If the atria and the ventricles are not communicating with each other, there's poor cardiac output and your patient suffers. Questions? All right. Again, this is a third degree block. Okay. What is your rate? Rhythm. Okay. Do you see P waves? Well, yeah, I've got a mark for you. Okay. Do the P waves look similar?
Yes.
The fact that they look similar tells you what? They're coming from the same impulse. They're coming from the same cell. Okay. Now, does every QRS have a P wave? Does every P wave have a QRS? No, it doesn't. This P wave right here has no QRS. What do you notice about the PR interval? What do you notice about the PR interval? Look at that PR interval and then compare it to this one, compare it to this one, compare it to this one. You really can't compare it to that one. Say it again. It is random, but now here's the thing you got to remember is that it's getting longer, longer, and longer, and we got to watch that closely, okay? What do you notice about this EKG as far as the QRS that's different than the ones I shared before?
It's still regular.
Well, your RRs will be regular, or your QRS complexes will be regular on the others as well. But look at the width. Yeah, it is normal. Good. So understand that you can't just pick one thing out and say, oh, well, if it's a wide QRS, therefore it's got to be a third degree block. Here I've given you one that has a normal QRS, but you've got to identify it from the preponderance of the evidence, all of it, okay? Let me give you something that may help you to, as we're going through, because we're going to transition into a different type of junctional rhythm in just a second. But I want to give you a little chart that I've developed that may help you when you sit down and you look at a rhythm. Quite often, students will look at a rhythm and they'll say, that's a heart block. Not entirely sure what kind of heart block it is just yet. So let me show you something here. Let me clean this off a bit. So, I'm going to let that dry and come over here. One of the things we're going to look at is our PR interval. Abbreviation for PR is the letters capital P, capital R, with a line drawn over them. All right? And so we're going to divide our PR intervals up into two categories. On this side, we're going to call it a constant, actually, maybe. Okay, constant, and this one is a variable PR interval, so it's going to change. Okay, on this side, we're going to go with first degree. Over here, we're going to go to second degree type 1. Here, still not dry yet. We'll go to second degree type 2. And over here, we'll go to third degree. When you're looking at your PR intervals, and you look at it and you say, I'm like 90% sure that's a block. I'm not entirely sure what flavor of block it is. Go to the PR interval. Okay? Look at the PR interval. If the PR interval does not change and the other criteria for a block are in there, then it either has to be a first degree block or a second degree type 2. Can't be anything else. If you're looking at the PR interval and there is a change, whether it is a progressive change or whether it's all over the place like the accordion, it has to be either a second degree type 1 or a third degree block. Back a long time ago in a galaxy far away, when I was learning this for the first time, I struggled with blocks. And somebody showed this to me. And I have adopted this, and I share this with all of my classes since then. And it's helped me, okay? Any questions about blocks? All right, let's move beyond here. And let's do a little bit of a block review, okay? What is your rate? Okay. What is your rhythm? Are you saying regular or irregular? Irregular, okay. Is there a pattern to the irregularity? Well, yeah, there looks like it, right? We'd like to see a little bit longer strip, but we can identify this off 6 seconds. We think that there is, okay? Do you see P waves? Do they look normal? Do they look similar? What do you notice about the PR interval? Okay, it is constant. What does that automatically tell you? Especially if I'm giving you an exam, or not an exam, but a quiz on Wednesday of just AV blocks. What does that tell you which rhythms that this can only be? So we're looking at either a first degree or second degree type 2. Let's examine further, okay? Does every QRS have a P wave? Does every P wave have a QRS? No. What about the width of the QRS? Okay. So, ladies and gentlemen, boys and girls, what is this rhythm?
Type 2, second degree.
Second degree type 2 or type 2 second degree or Mobitz 2. I don't care what you call it as long as it's correct. Now, let me take a break here, okay? Anybody not understand, because again, this is part of that communication, not understand why this is a second degree type 2 block? Yes?
The one that Winkebach, can we also call this Winkebach?
That's second degree type 1. Mm-hmm. Second degree type 1. Yes?
What does it say, like, to determine if it's one or the other? What does it say at the top?
PR interval. I'm sorry, it's plain scribble. I'm right, not Catherine is. I pick on people I like. It's the PR. You're talking about right here?
Like, what does it say to the left and right?
Oh, constant. So is the PR interval constant? And over on the right, it's variable. Okay. Any other questions? Rate. Rhythm. P waves. Do they all look similar? Do they all look normal? PR interval. Okay, what else do you need to know about the PR interval, though? Say it again. Width. What's the width of this? Let me make it a little bit bigger for you. So it's abnormally long, and you said that the PR interval is constant, right? Okay, good, good, good. So that automatically tells us that this can only be a first degree block or a second degree type 2. Now, be careful here because several of you failed to completely identify a rhythm strip, and you only got half credit on your quiz. Okay, so if it's a first degree block, when we get done dissecting it down, remember you got to tell me the underlying rhythm as well. Does every QRS have a P wave? Does every P wave have a QRS? Okay, that's another indicator that it can't be a third degree block. It can't be a second degree type 1 or a second degree type 2 because those three blocks all have more P waves than you do QRS. What do you notice about the QRS width? What is this rhythm?
First degree AB.
What is this rhythm? Say it again. It is, okay? I was in a hurry when I made this slide, so I just put the first degree block because I wanted to make sure you got that. But understand, with first degree block, you always have to identify the underlying rhythm. And it's almost always going to be normal sinus rhythm or sinus bradycardia, okay? Yes?
So 2 and 3 are their own rhythms.
2 and 3.
Second degree and third degree are their own rhythms.
I'm not sure if I understand your question.
Well, you said this one is just a superimposed on another rhythm. Are second degree and third degree their own rhythms?
Yes, I see what you're saying now. So yes, basically what this is an aberration of usually normal sinus rhythm or sinus bradycardia. With the other three forms of AV block, there is no underlying rhythm. They are their own rhythm. Yes, you are correct. Anybody else? Rate. Rhythm. Do you see P waves? Okay. Do they look normal? Does every QRS have a P wave?
Yes.
Well, does every P wave have a QRS? What do you notice about the PR interval? Not irregular, variable. Okay, which means automatically come over here to the side of the chart. Now we've taken, even if we're in a situation of where we have to guess, we've taken our chances of getting it right from 1 and 4 down to 1 and 2. So it either has to be a secondary type 1 or a third degree. Ladies and gentlemen, do you see a pattern to the PR interval?
No.
That's important. What do you notice about the QRS? It is normal. So, name that tune for me.
Third degree AB.
That's third degree AV block. You could also call it what? Complete heart block. Okay? So you could call it complete heart block and you would be perfectly okay. Everybody clear on that? Not clear. Okay. What you were tacking along so well? What derailed you?
I guess the QRS width.
Okay.
I thought it had to be longer.
He was in the bathroom when you explained.
Oh, okay. So again, when we're looking at here, you're talking about the width of the QRS being within normal.
Yeah.
Okay. Sometimes the QRS will still be narrow. Now, okay, let's think about this. Going back to the conduction. Okay, let's do it this way. Let's say this is our heart. Okay. Atria ventricles. Here's our septum. Okay. Now, remember the normal conduction pathway of the heart. Starts at the SA node, comes down to the AV node, goes down through the bundle of His, down through the bundle branches, spreads out to the Purkinje fibers, and then back up through the ventricles. Okay. What might exist that would cause this QRS, which is being paced by the ventricles, what might exist that would cause that to look narrow? Because remember, what did I say? The widened QRS is caused by what's called aberrant conduction. It goes the wrong way. It takes a shortcut. It goes a different direction. What might exist that would cause that QRS to be narrow and yet it still be third degree block?
It's coming from like higher up.
Not higher up. Actually, probably got an impulse down here in the bottom. Why? Because the normal pathway to depolarize the ventricles is this way. Okay? Now, if we've got one that is coming up from up in here, first of all, it has to come down and then it has to go back up. That's what makes the QRS wide. But if we got an impulse that comes down here near the apex of the heart, that is one of the reasons why your QRS could be narrow. This is really, really important as to why it's critical that you make sure that you are solely looking at the 5-step process. Questions? Does that help? I mean, are you still lost? I mean,
understand more.
okay.
What is this? Is that like your S?
So the question is this a P wave or is this a T wave? And my argument would be is that it is a P wave. Why? Because we can see that we got a P wave over here. Okay. And so this one is smaller, but it's similarly shaped. But one of the ways that we could do it is we could identify two P waves that we can see, this one and this one, measure the difference, and then measure the difference again, and then this one should come up there in the middle of it if we measured across 3 of them. Other questions? Yes.
So is lead 2 an upside down view of the heart then?
Lead 2 is basically looking from here down to here.
So here it's going towards the lead.
Yep.
And then when it gets down here, it's away from the lead.
Yep. From the positive lead.
On this little diagram you saw, going towards the lead. When it goes up here, it's away from the lead.
Yes. But now again, remember that it follows the normal conduction pathway. And the normal conduction pathway coming down the ventricles is here's your bundle of His, branches out into your left and right bundle branches, comes down, and then it breaks out into the Purkinje fibers.
What I'm saying is when it does that, it's going away from the lead.
It's going back up towards the lead. Because remember, looking from here down to here, when it gets down to this part of the heart, it branches out and it comes up this way. So go and look at your diagram of your heart, of the conduction system of the heart, and look at those Purkinje fibers and look at what direction that they are pointed. So it's kind of like following an interstate. It comes down, and then they branch back up, coming back up towards this lead. I think I fried your brains. I see a few heads nodding. That's where we're going to stop. When you come back on Wednesday, the beginning of class, we will have a quiz that is only first degree. If you want full points, you got to identify which one is the underlying rhythm. Secondary type 1, or a Winky Bach, or a Mobitz 1, whatever you want to call it. Secondary type 2, or a Mobitz 2, or a third degree block or complete heart block. Not a Mobitz 3, okay? Only one of those 4 rhythms will be the right answer. And only those 4 rhythms will be the ones that will be on your quiz, okay? Everybody got the bonus points for your online quiz, again, because of the level of discussion that you're bringing to class. I do want to see that a little bit expanded from some of y'all that are quiet, because usually the quiet people are the smartest people. So I want to hear more from those of you that are quiet, okay? Come see me if you want to talk, if you need. Oh, I'm sorry. Yes. That one, Catherine. Josie. Thank you for reminding me. Matt. Travis. Carson.
Sorry, thank you, sir.
Uh-huh. Oh, I'm sorry. Yeah. Caden. Born. I keep forgetting. That's right. We got 2. Caden Elliott. Nathan. Braden. Dylan. Sydney. I think I just gave it to him. Nathan. There you go.
Thank you.
Uh-huh. Kelsey. Naomi. And Emmy. Were you here for?
I missed the day.
What you missed? You were not here.
No, I said I haven't missed the day. There's not one for Brennan.
No, let me look and see. If I find it, I'll scan it and send it to you. I'll tell you what. Let me do this. Let me see if I got a score for you.